Next, can I call upon Professor Dr. Arul Raj and Dr. D. Ramesh to come on stage to chair the next session.
Very good afternoon. So we'll start the next session.
Good names. Close one, Dr. Hari Krishnan.
Happy to.
Legal force in that.
Yeah, sir. So good afternoon all. So we'll start the next session. So by Dr. P. Hari Krishnan sir on early glyphosation of type 2 diabetes patients, care me treatment.
Thank you very much. And I am actually a stranger in this conference. I think I'm a cardiologist. Professor Chandrasekhar from Cardiometabolic Congress is my 1 year senior from Stanley, actually. I've been to various similar conferences. The past one also I presented. So I've been given the task of talking about dapagliflozin especially and how we do it. And I'm really proud to tell that in my cardiology practice, I have very close relationship with my nephrologist and diabetologist also. So a care me approach, they call it actually. So cardiac, renal and metabolic. So that's the way it is going now. So all of us are joining together to get the cardiac risk and cardiometabolic risk and cardio-renal risk down. And one of the best things we could do is like join together and try to help each other. We know that about 10 to 15% of the world's population has diabetic population have CKD. Also, these about 10% of them definitely can lead on to heart failure also. And it's a big amount actually, about millions of people, 843 million now CKD, 64 million heart failure, and about 58% of the type 2 diabetic patients will develop CKD in the longer run. And the stats in India are staggering actually, the number of crores of people we have. And the youth get diabetic and heart failure very early, and we know that about 50% of people develop a heart attack by the age they are 45 in India, and so that is the major problem actually. So if you look at the unmet need of even after treating sugars very tightly, we still have ongoing heart failure events, ongoing cardiac events, and ongoing renal events, and we are not sure what to do. And very strict control versus poor control in various studies, like the previous studies in 1990s, didn't really abolish the risk of heart failure, and we are not sure how we can tackle these patients very early. And again, intensive management of diabetic nephropathy, again, still there is a residual risk ongoing. And if you look at the data here, so in spite of being very strict, like intensive, HbA1c levels of less than 6.5, still the residual risk is there. Even though there is a good benefit, still the residual risk is still ongoing in, the big studies actually. So what we as people know, as doctors know, is like for a cardiac first comorbidity which identified in the cardiovascular risk-free patients. So it's a big study about, this is a database study from both Europe and Japan, combined together a big amount of 137 patients tested in this trial. They followed people who were really naive of any cardiovascular disease and diabetic patients, kept on following them up, and then saw over about period of 4.5 years, nearly about a substantial amount of about 66 people who were renal free. About 18% of them developed a new onset of cardiac and renal diseases actually in the longer term. And if you look at the intrinsics, about 25% of people developed heart failure, about 36% of people developed CKD, and peripheral arterial disease, MI, stroke, all these things. And we know that there is a close interlink between these group of people. So beyond sugar control, what else should we do? Are there any molecules we can treat? And there was a fascinating talks about prevention, about vaccination, about what we can do to identify these people early, like in type 1 diabetes. Similarly, in type 2 diabetes, what should be the oral anti-diabetic drug we should be preferring? earlier on, it's not about just sugar control nowadays, it's about cardiovascular benefit and cardiovascular risk prevention. So SGLT2 has robust glycemic control with low risk of hypoglycemia, with cardiorenal benefits, and we know that without outcome data, we can't get a diabetic drug to the market nowadays. And dapagliflozin and empagliflozin have proven to be safe and also prevent in heart failure across the population, both in heart failure, preserved ejection fraction, mildly reduced ejection fraction, and reduced ejection fraction. About CKD, if I miss somebody with an SGLT2, my nephrologist starts them on a SGLT2 inhibitor. And already, if I look at the different prescriptions, already some people put a different brand of SGLT2. So I have to be very careful when I'm doing my prescription. Already, sir, this medicine I'm already on, or in some other form. So that's how it is going now, actually. I'm so much proud that we are all working in collaboration with each other, actually. So our cardiovascular and renal benefits in atherosclerotic cardiovascular disease prevention and treatment, these are also very much seen. Even GLP-1 receptor agonists are actually coming up slowly. Both there is some data now about heart failure in them, actually. So in the next talk today I'm doing 3 talks today. This is the first talk I'm starting off. So the next talk I'm doing is on GLP-1 receptor agonist in some other podium, actually, today. So they have, in fact, heart failure evidence ongoing now, along with obviously weight loss, metabolic, and also some renal safety data is there. So if you look at the algorithm here, now this algorithm is fascinating, actually. So if you look at the red is for heart failure prevention, the brown is for renal disease prevention, and this side is for indicators of high risk, anybody with hypertension, anybody with other risk factors, already having smokers, dyslipidemia. Most of us come in this category now, and in such patients, I think earlier the better. Start with an SGLT2 to start off with heart failure SGLT2, CKD with the GFR more than 20, go for an SGLT2. And again, if you want to fastly control the risk factors, reduce the weight and things like that, go for an SGLT2 along with the other medications. So this is how the algorithm is going now, actually. So if you look at the kidney disease improved global outcomes guidelines, the 2022, and it's a very simple algorithm. If you look at lifestyle modifications, start off with first-line therapy, start with metformin. If it is the eGFR is less than 45, reduce the dose, less than 30, discontinue dialysis. This we know, this is an old data. And SGLT2 inhibitors, if the eGFR is less than 20, do not initiate. Otherwise, you can actually, and dialysis discontinue. And go for other preferred algorithm. GLP-1 comes on the top. Cost is prohibitive at present, but I'm sure it will come down as we do and more usage. And go for the other medications as we go down the risk and patient preference also. Now, if you look at the DAPA indications for diabetes and other concomitant recommendations. So if somebody has type 2 diabetes, CKD, and an eGFR of more than or equal to 20, to go with an type 1 indication, class 1A. And the recommendation, if somebody has albumin creatine ratio, proteinuric of around 20 milligrams per millimoles, then go for an SGLT2 inhibitor, and the indications is high, or somebody with a heart failure, irrespective of the level of albuminuria. If somebody has less, not albuminuric, but eGFR is on the lower side, then go for an SGLT2. And this is again, the nephrologists are really wanting these medications like this to prevent a decline in the eGFR, which they often see in their patients, often frustrating. Heart failure, we are really very much blessed to have agents like SGLT2 and RNA inhibitors, which has really revolutionized the way we treat heart failure. We don't see many failure in, heart failure is very depressing to treat, actually. Unlike other therapies, it's even worse than cancer. Actually, heart failure is so bad. So if you look at the amount of people who are surviving after a heart failure event, after 5 years, only 50% are alive, actually. So SGLT2 and RNA inhibitors have really revolutionized the treatment in this area. And if you look at DAPA or EMPA, it comes on the top, of treatment. One of the pillars, you would have heard about all the pillars of heart failure. Now 5 pillars are there, including vericiguat, Four pillars, this is an essential pillar. SGLT2 inhibitor doesn't have much in the form of contraindication apart from, people like low BP, people who have low potassium, people who have, where you are unable to initiate other medications. So you can use an SGLT2 inhibitor actually in such population. Only thing is indwelling urinary catheter, if somebody has, then they will be prone for UTI. So you have to be a little careful. Once they are out from the CCU or HDU, then you can initiate. So that's where we stand now, and it is a class 1A recommendation. So management of heart failure with preserved ejection fraction. Again, my research in UK was on diastolic heart failure. At that point, I studied valsartan in that population, and we found that valsartan is part of ARNI. So valsartan was beneficial in my PhD thesis on that. So now we have SGLT2 inhibitor. We were really looking for any agent which could help this population, which has as bad mortality as a person with a preserved ejection fraction. Often what we tend to do is we ignore this population because they are breathless, they think we are fat, or we are actually having just lack of, they are not fit or things like that. But often this population is very bad with a stiff ventricle. Often we tend to lose them. And SGLT2 has been a welcome therapy for these people actually, the preserved ejection fraction. Again, class 1 recommendation along with the other usual treatment modalities, including strict lifestyle modifications. And in glucose reduction, we all know, you guys will be the expert in this, as much as 1.4 to 1.5% reduction in the long term, and it's a sustained reduction over several years, and it doesn't really come down or crossover. It's a sustained reduction in spite of not having any rescue therapy in several studies we know. And what about the cardio-renal benefit? Again, I'm not very much qualified to talk about this, but we have studies like DECLARE study and the DAPA CKD study, which shows that whatever the level of the albumin excretion, you still have patients who are benefiting across the range of all types of proteinuria in a large population of about 17,000 patients tested over a period of about 4 years and odd. And you have a sustained reduction of all the renal composite endpoint, including decline in GGFR, renal death and cardiovascular death, everything put together. You have a sustained improvement and benefit in people who are treated with the dapagliflozin. And again, DAPA CKD, again, in that population, again, you have, this is a very dedicated study just for CKD. It's one of the very unique studies which shows that, again, there is in the all-cause mortality, composite endpoint, of renal endpoints, and heart failure endpoints are really, so it's like a magic molecule, I think, actually, of this decade, whatever we can know. And regardless of the glycemic status, either normal glucose, pre-diabetes or diabetes, often people, when I prescribe this molecule, they all say, the pharmacist told that you don't have sugar, why you have this molecule? And I have to answer all these patients actually. Often I have to explain to them. And nowadays when I prescribe itself, I tell them, this might be the question you might be asked, or don't worry about it. So that sort of an awareness is, I think we have to be, improving the awareness amongst the people who are really dispensing the medication. And again, heart failure wise, we are really fortunate to have this molecule. This is in preserved heart, this is in decreased heart failure, reduced ejection fraction, amazing, improvement in the outcomes. And if you put both the spectrum of people with reduced and preserved ejection fraction, throughout the spectrum we have benefit in this with this molecule. So both prevention and therapy, and cardiac, renal, metabolic, if you have right from prevention up to treatment, you have great benefit. And is it easy and safe? We know it is actually, you could have UTI, but you have to warn them, try to keep the hygiene better, and try to make sure you are actually genital hygiene, and make sure you actually, take measures to prevent it, and report it early so that you don't miss and end up with a severe infection. And obviously you have to be careful about that. So may increase hypoglycemia, but compared to other medications, a lot lower, and you have to be careful about telling them in case, then report it to us. And safety profile has been tested in several trials and a large database we have. And so you can use it in people who are really sick and unwell patients also in this trial. we told that clear advantages over people who were recently hospitalized and frail people didn't have major issues with initiating this therapy. And so I would just, tell that go for, if you have, the will to treat a patient with cardiac, renal, and metabolic, and start early with a good medication which has more scientific evidence, and try to make sure you maximize the benefit of these patients. And thank you very much for patient listening. Thank you.
Thank you, sir, for the lucid presentation. I have a doubt, sir. So regarding, as mentioned, the spectrum of heart failure, early glyphosate usage is definitely useful. So what is your experience in elderly patients, so those who present with hypovolemia, dehydration, and expectation of AK in those patients with early glyphosate start?
So when somebody is very acutely unwell, we don't start actually. Obviously, we need to stabilize them. For example, if somebody ends up in CCU, then we make sure we are making them better, hydrated first before we can start them, if that's your question. And in heart failure, again, you have to stabilize them first before initiating them. But might be one of the first medications we could start, might be first go on with a diuretic therapy. Make sure you actually make sure they are coming off their inotropes. Make sure they are, euvolemic before you can start them on it. We know that these medications have to be stopped before any major surgeries where people can lose volume. Like sir is rightly telling that before people are able to, get clearance for a surgery, then you have to be careful, screen their, thing, and then make sure that the glyphosins, should be just avoided for around the surgery time. So those things you have to be careful.
So, in combining for obesity,
yes, sir,
for weight loss, combining GLP-1 and the glyphosins, any
yes, sir,
experience?
Yes, sir. So recently I've been using a lot of GLP-1 analogs also actually, even though off-label, some of these patients were not diabetic also actually. I've been using it. And phenomenal benefits, sir, actually, phenomenal benefit. And sometimes I use, with the DAPA or EMPA along with GLP-1, amazing benefit, 20 to 25 kilograms loss. And they're completely different person actually. They have stopped they don't need any further statins, and they don't need even BP medicines actually. So it's a phenomenal difference, especially in people who are very obese, and I've been very big advocate of using them. Yes, sir.
So any questions, sir?
Thank you very much. Thank you.
Thank you, sir. So this we can move on to the next session. Topic: Managing Hypertension and Diabetes at Double Jeopardy by Professor Dr. Sadashiva Rao. Welcome, sir.
Yeah, good evening. And at the outset, I would like to thank the organizers, Shanmugam and his team, for inviting me for this conference. And I bring greetings from APRSDI, and I also welcome you to APRSDI that will be conducting in December 20th in Kakinada, the port city. So I've been asked to talk on diabetes and hypertension at Double Jeopardy. As all of you are aware about this, hypertension and diabetes do coexist together, and patients with diabetes are twice likely to have hypertension, and the presence of both these two lifestyle diseases increase the incidence of coronary heart disease, cardiomyopathy, stroke, peripheral artery disease, and end-stage disease, and microvascular complications. The prevalence of diabetes and hypertension in India are high across all geographical settings and socioeconomic groups in middle and old age. In the morning, Dr. Anjana Mohan also has talked about the prevalence of hypertension in diabetes in here and even in around the country, which is around 40+%. And the crude prevalence of diabetes and hypertension is around 8% and around 25.3%. We look at this, hypertension is more common in individuals with diabetes than the general population, with the estimates of the prevalence of hypertension in the diabetes ranging from 40 to 80%. And if you look at the interaction of insulin resistance, type 2 diabetes and hypertension in metabolic syndrome, see, on one side you have the activated RAS and sympathetic nervous system activation, and the end result is reduced CV bioavailable nitric oxide, and increased endothelial lack and stiffness, resulting in hypertension and vascular stiffening. Other hand, you have the abnormal release of EVS and microRNA, and result is hypertension and vascular stiffening. So the patients with diabetes have more isolated systolic hypertension, and because of the autonomic neuropathy, experience less reduction in nocturnal BP and higher baseline heart rates than their non-diabetic counterparts. And they also have enhanced variability in BP, and they're prone to develop orthostatic hypertension, and their hypertension is more resistant to treatment. And here, the control of hypertension in these patients presents a great challenge because the targeted BP is quite low and the response to treatment is often poor. If you look at the coronary heart disease and cardiomyopathy, the Framingham cohort has shown that the incidence of coronary artery disease and CVNs were significantly higher in diabetic patients with hypertension and in those without hypertension. And the prevalence of left ventricular hypertrophy was 72% in diabetic hypertensive patients and only 32% in non-diabetic counterparts. And all of you are aware that hypertension accelerates the progression of diabetic nephropathy. The risk of developing end-stage renal failure, if an optimal blood pressure of below 120/80 was used as a reference, increased by 1.9-fold if BP is around 130 to 139, increased by 3.1-fold in the case of mild hypertension, which is in the range of 140 to 159, and increased by 11.2-fold in the case of severe hypertension, that is above 180. If you look at the effects of blood pressure on progression of diabetic nephropathy, high level of albuminuria, mean systolic blood pressure 140 or higher, and mean diastolic blood pressure 80 or higher were associated with worse kidney outcomes. The influence of hypertension on microvascular disease is already been well known that there is an increase in 2 to 3-fold rate observed in diabetics than non-diabetics, and hypertension was the most significant risk factor for arteriosclerosis, and hypertension as a complication in diabetics further increases the frequency of developing CVD by 2-3-fold as has been stated, and compared to normotensives, non-diabetics, the rate of onset of CVD is 5 to 7 times higher in diabetic patients with hypertension. And coming to the point of hypoglycemia, hypertension, and arrhythmias, because hypoglycemia activates the sympathetic nervous system, it has a variety of influences on the cardiovascular system. And arrhythmia also frequently occurs during asymptomatic hypoglycemic periods. And hypoglycemia mortality rate is reported to be 10%, and also all of you are aware about the dead-end bed syndromes. And arrhythmia occurs during hypoglycemia is likely to be one of the reasons for the increase in the CVD death observed during the strict blood glucose control. And relative risk of CVD occurring during serious hypoglycemia is reported to be 2.05 folds. And presence of microvascular and macrovascular hypertensions and normotensives with or without morning hypertension. So morning hypertension has significantly higher frequency of developing nephropathy and retinopathy. The frequency of developing a cerebrovascular disorder is also higher with morning hypertension. And we all know that we measure BP right from the first visit, and at every visit, subsequent visits, we try to monitor the BP. And if BP is found to be more than 140/90, we again try to record it out in multiple times. And if it's above that, we try to start treatment. And we ask the patients also to monitor the BP at home also. So thanks to the COVID, now people are aware about hypertension monitoring. All of them have monitors. They monitor BP at home, and they tell me, doctor, only when I come to the hospital that I have BP. At home I don't have it. So you know about the coming to the hospital, wherein it's called the white coat syndrome, wherein I think we don't have to do anything. All hypertensive patients, we should monitor the BP at home. And the treatment goals should be treated to a systolic BP goal of 140 and a diastolic BP goal of below 90. Lower systolic and diastolic BP targets such as 130/80 may be appropriate for individuals at high CV risk. In pregnant patients with diabetes and pre-existing hypertension who are treated with antihypertensive therapy, BP targets in the range of 120 to 160, 80 to 105 are suggested in the interest of optimizing long-term maternal health and minimizing the impaired fetal growth. Coming to the targets in hypertension targets in people with elderly above 65 years. So the College of Cardiology, American Heart Association 2007 guidelines has stated that a BP of less than 130/80 of independent of comorbidities and level of cardiovascular risk and patient age, whereas the European Society of Cardiology and European Society of Hypertension 2018 guidelines recommend a BP of 130 to 139 and by 70 to 79 in patients aged more than 65 years with hypertension and diabetes. The most recent hypertension guideline 2020 has taken an intermediate position indicating that BP should be lowered if it is more than 140/90 and reduced to 130/80 in younger adults and to below 140/80 in the elderly. Most recently, the 2021 best practice recommendation of the ADA recommends individualizing the target BP with a goal of below 140/90 and overall to a target of BP below 130/80 only in patients with a 10-year cardiovascular risk more than 15%. So lifestyle intervention actually is a must, is a cornerstone in the treatment of diabetes and hypertension. So patients with BP more than 120/80, lifestyle intervention, achieving a weight loss if overweight or obese does help us in the control of diabetes as well as hypertension, and a DASH approach, a dietary approach reducing sodium, increasing potassium intake, that's fruits, or moderation of alcohol intake, and increased physical activity is advised. And coming to the hypertension and diabetes prevention strategies, primary prevention, where is an individual and the population at large, patients have to be educated about the nutrition and physical activity. The important incorporate the obesity and diabetes prevention into the daily in the practice, and also telling the patients to cut down on salt and all. So next slide, we'll go on to the hypertension control, BP control recommendations. And we usually start with the ACE inhibitor or ARB. The maximally tolerated dose is used, indicated for BP treatment is the recommended first-line treatment for hypertension. The patient with diabetes and urinary albumin to creatinine ratio more than 300 milligrams or 30 to 299 milligrams, and that is a urinary albumin creatinine ratio, that's incipient nephropathy, and if one class is not tolerated, the other should be substituted. That is, if you are using ACE inhibitor and if they are not able to tolerate it, you can change to ARBs. So you should use the maximum tolerated dose to achieve the targeted goal of hypertension. So patients treated with ACE inhibitor, ARB or diuretic, serum creatinine should be estimated, and the eGFR and also serum potassium levels should be monitored at least annually. You look at the number of medications the patients were put on in the various hypertension and diabetes trials. Almost more than three medications were put on in almost all the trials. Here you can see here the management of hypertension in type 2 diabetes mellitus Indian guidelines 2024 by the API, Indian College of Physicians, which shows that in almost they have maintained the target BP below 140/85. And here the ADA 2024 recommends if the BP is in the range between 130/80 and below 150/80, start with one agent and lifestyle management. And if albumin or coronary artery disease is present, start AC or ARBs. If it's not there, if albumin or coronary artery disease are not there, you can start either of any of the drugs mentioned in this slide. Yeah. If initial BP is more than 150/90, you have to start two agents. And like we start in diabetes, the fixed dose combinations have come into practice early in the treatment of diabetes. Like that, we have to start two agents in order to bring down the BP below 150/80. And if albumin is there, you can start the third agent along with the combination. And if they are not there, either start one of the combination of drugs and then if assess BP control and look at the adverse effects. If treatment tolerated and target is achieved, continue the therapy that has been already put on. And if not meeting the targets, add agent from the complementary drug class, like AC or ARB or calcium channel blocking agent or a diuretic. If adverse effects are there, consider changing to alternative medications. If a patient is on ACE inhibitor, go for IRB. If they are on ARBs, then change over to ACE inhibitors. Add a calcium channel blocking agent or a diuretic if they are not meeting the targets. And assess BP control and adverse effects, and not meeting targets or adverse effects, use a drug from each of the three classes, and consider addition of the mineralocorticoid receptor agonists that have lately come into practice, and refer to specialists who expertise in BP management, if not at control. Coming to the recommendations combination, I am not going to this, all of you are aware about this. The preferred drugs are, as been mentioned, the ACE inhibitor plus diuretic, ARB plus diuretic, ACE inhibitor and calcium channel blocking agents, ARB and calcium channel blocking agents. Acceptable are the beta blockers and the calcium channel blockers, renin inhibitors plus diuretic, and renin inhibitor ARBs and other things. If diuretics were made the criteria, the rate of reduction in the new onset of diabetes is reduced by 43% with ARBs, 33% with ACE inhibitors, and 25% with calcium channel blocking agents. So telsartan can better improve the insulin resistance compared with other ARBs. So compare them, we have a lot of calcium channel blocking agents in usage, and the most preferred are the cilnidipine and amlodipine. Amlodipine actually increases the heart rate, and its effect on norepinephrine is also increased. So, and cilnidipine is acceptable alternative to antihypertensive for patients with amlodipine-induced edema. So, in addition to blocking the RAS system, and telmisartan can also definitely improve the insulin resistance and reduce the insulin levels, and therefore it could be speculated that telmisartan is superior to other ARBs in reducing and delaying the occurrence and development of type 2 diabetes mellitus in patients with hypertension and insulin resistance. So here the clinical question of blood pressure lowering in patients with diabetes. So you have, what is the blood pressure threshold to prevent cardiovascular events? Since below 140, mortality is decreased, ischemic heart disease is decreased, and also stroke is reduced. If you reduce it below 130, mortality is reduced, ischemic heart disease questionable, and stroke is reduced. If it is below 20, no adverse effects are there. It's achievable if there's a nephropathy and renal morbidity is there. And blood pressure drops with improvement of hyperglycemia is soon. With the introduction of the SGLT meters, we have seen the drop in the A1C, body weight, and systolic and diastolic blood pressures. And look at the GLP receptor agonists, the SGLT inhibitors, and even the mineralocorticoids, all of them have an effect on the hypertension, wherein they reduce it. And dapagliflozin, here you can produce consistent BP reduction of 4 to 5 millimeters. Oh, thank you.
Thank you, sir, for the excellent talk. So I highlighted the guidelines nowadays defining the target blood pressure of less than 130 by 80 in the diabetics than rather the normal population where the target is 140 by 90. And what's your take on the beta blocker usage, sir, in diabetics? Normally we don't prefer that. So
actually in practice, we don't use it, but if the heart rate is high, if tachycardia is there, I think we can start using the beta blockers along with consultation, along with the cardiologist.
Bivolol?
Yeah.
And when to use this carvedilol?
Carvedilol.
Yes. Which one is preferable on these three things?
You can use nebuliol and carvedilol also.
As comparison, these three, which one is better, which one is best to select this? Nebuliol or carvedilol or metoprolol? All are equal effect, or?
I think all of them have an equal effect, but in diabetes mostly the carvedilol and nebuliol is preferred. Right.
Sir, in case of diabetic and hypertension in middle age groups, in your vast experience, have you seen the infertility and in case of males and in females pelvic organ prolapse? Because in recent heart article they have told that when a patient has hypertension and diabetes together, they have more chances of pelvic organ prolapse. In your experience, sir?
No, I didn't come across any. Maybe Sundaram sir can answer that.
Experience prolapse of the uterus is much more in patients with diabetes and hypertension when you use these things. Even day before yesterday we.
Thank you.
With this, can we move to the next topic? Topic is sarcopenia and diabetes, a bidirectional relationship and its clinical implications by none other than Professor Dharmarajan sir. Welcome, sir.
Good evening, ladies and gentlemen. With due respects to my teachers, Professor Sundaram, Professor Rajendran, my senior junior colleagues, at the outset I'd like to thank the organizing and the scientific committee of TRACK 2024 for giving me this opportunity to talk on this important subject. Sarcopenia and diabetes, a bidirectional relationship and its clinical implications. Nothing to disclose. And let us start with the case Vignet. This is a 67-year-old male. He is a known diabetic for the past 7 years, coming with the chief complaints of a gradual decline in strength, stamina, and overall functional capacity over the past 1 year. His hands and legs would start hurting or paining, or even after performing smaller tasks, or even walking for 5 to 10 minutes. He is currently on metformin and dapagliflozin. He has a sedentary lifestyle, non-smoker, and has quit smoking after the diagnosis of diabetes. On physical examination, this patient looks tired, has a protruding abdomen, his weight is 82, height is 165, BMI is 30.1. Waist circumference is 105, obviously he's obese, right? And muscle strength in the upper extremities, arms, hands and fingers, lower extremities 3+ bilaterally. And on laboratory evaluation, his fasting blood glucose was 148, postprandial is 216, HbA1c is 7.9, CRP is 1.7 elevated, rest of the other investigations are normal. Diagnostic assessment or functional assessment of the individual showed that DEXA scan showed a low muscle mass, appendicular lean mass index below the 5th percentile for his age and sex, and hand grip strength measurements showed a decreased grip strength compared to the age matched reference values. His hand grip strength was 18 in the right and 16 on the left. Normal is more than 27. So with this parameters, what will be the diagnosis in this case and why? And that is the topic of our discussion today. This patient was diagnosed based on the examination investigation findings. The patient was diagnosed with sarcopenic obesity with type 2 diabetes. Sarcopenia was diagnosed based on the reduced muscle function, the low muscle mass, and decreased physical performance. And obesity was diagnosed based on the high BMI and the elevated waist circumference. Now let us go into the topic proper. The plan of my talk over the next 12 minutes would be to give you an introduction, discuss the pathophysiology of sarcopenia and diabetes, and what is this so-called bidirectional relationship? What are its clinical implications? On the evaluating and managing a patient with sarcopenia and diabetes, and the role of anti-diabetic drugs, and prevention, is it possible? And then conclude. The term sarcopenia was first coined by Irving Rosenberg way back in 1989. And the term sarcopenia was derived from Greek terms, sarx, which means flesh, and penia, which means less or loss. So diabetic sarcopenia is defined as a disorder which is characterized by the presence of diabetes, type 1 or type 2, and sarcopenia. Sarcopenia is associated with reduced mobility, increased incidence of falls and fractures, functional disability, and dependence. While sarcopenia and diabetes put together, they are associated with higher degrees of hospitalization, risk of CV events, and mortality. And all of us know there occurs a progressive and generalized physiological loss with aging. Physiological loss of muscle mass with aging, which is about 8% per decade between the age of 40 to 70 years, and thereafter, above the age of 70 years, it is 15 to 25% per decade. The prevalence of sarcopenia varies depending upon the population studied or depending upon the criteria that we use for the diagnosis of sarcopenia. It varies between 8 to 40%. At any point of time, it is 2 to 3 times higher in diabetic patients when compared to non-diabetic individuals. If you look at the muscle strength health scenario in Indian adults, 7 in 10 Indian adults have poor muscle health and low protein levels. And if you thought working Indians are better than the non-working Indians, we are mistaken, because working Indians are only marginally better shape than non-working Indians. The prevalence is only a little more in the non-working Indians. Even working Indians have a high incidence of poor muscle health and low protein levels. And this is how, as we age, sarcopenia sets in with the loss of muscle mass and increased fat and fat infiltration into the muscles, you get muscle loss and function. This is the progression of sarcopenia with aging. Now let us discuss what is diabetic sarcopenia. According to the Asian Working Group on Sarcopenia Consensus definition, sarcopenia is defined as an age-related decline in skeletal muscle mass plus a low muscle strength plus poor physical performance. So all these three things should be there to make a diagnosis of sarcopenia, diabetic sarcopenia. And sarcopenia is a progressive systemic skeletal muscle disorder which occurs as an age-related process associated with frailty, falls, fractures, physical disability, mortality. And the sarcopenia and diabetes have a bidirectional relationship. They increase the risk of each other. And the hallmark of diabetic sarcopenia is muscle mass atrophy. And this loss of skeletal muscle is excessive and it's independent of the body weight changes. Whether the patient is obese or lean, it is independent of the body weight changes, especially in the setting of diabetes, hyperglycemia, and insulin resistance. And it is much more common in women when compared to men. But if you look at the converging risk factors for sarcopenia and diabetes, the most important, the most significant risk factor for the development of both sarcopenia and diabetes is aging. As aging advances, there is a gradual loss of skeletal muscle mass and function, leading to a reduced glucose uptake by the skeletal muscle. After all, we know skeletal muscle is the largest organ of the body and is the most important organ for peripheral glucose uptake. It caters to about 80% of the peripheral glucose uptake. So there occurs insulin resistance and reduced glucose uptake, contributing to hyperglycemia. And redistribution of adipose tissue from the subcutaneous to the visceral tissue. And there is a threefold increase in the intramuscular fat stores. And there is an imbalance between the muscle protein anabolism and catabolism. Catabolism takes over, anabolism becomes less, and so there is muscle loss. And there is an increase in the inflammatory markers. We all know diabetes is an inflammatory state. So there is an increase in inflammatory markers, increased oxidative stress, and there is mitochondrial dysfunction, and there is accumulation of advanced glycation end products. So all these contribute to the development of sarcopenia in patients with diabetes as age advances. Apart from that, there is reduced testosterone levels, reduced energy requirements, decreased vitamin D levels, smoking and physical inactivity acts on top of all these to cause sarcopenia in patients with diabetes. This is a pictorial representation of what we have been discussing earlier. Apart from aging, the other risk factors for development of sarcopenia. What is the metabolic pathophysiology of sarcopenia and diabetes? The most important factor which causes, the most important pathophysiologic abnormality which causes sarcopenia in patients with diabetes is insulin resistance. Especially insulin resistance in the part of skeletal muscle, there is the most important factor which causes downregulation of the mTOR metabolic pathway, thereby tilting the balance between protein synthesis and breakdown. So protein synthesis becomes less, breakdown becomes more, and there is muscle loss. And second one is the inflammation, a chronic low-grade inflammation, thereby increased inflammatory cytokines like your interleukin-6 or TNF-alpha or CRP, they all disrupt the glucose and muscle homeostasis. Increased oxidative stress caused by increased reactive oxygen species, decreased antioxidant effects, accumulation of advanced glycation end products that can lead to skeletal muscle atrophy and dysfunction. And then the IMAT, intramuscular adipose tissue deposition, that increases the insulin resistance in the part of the muscle and impairs the contractility and elasticity of the skeletal muscles. And finally, gut microbiota. I was surprised, and we'll be surprised how gut microbiota can play a role in causing skeletal muscle dysfunction. There is something called phenolic conjugates, which is produced by gut microbiota and which is supposed to be good for the muscle function, maintenance of muscle mass. And this phenolic conjugates is reduced in patients with diabetes. This is supposed to influence the onset and progression of sarcopenia in patients with diabetes. This is again a pictorial representation of how diabetes and sarcopenia share a bidirectional relationship, with aging as the central precipitating factor and insulin resistance playing a major pathophysiologic role in the causation of sarcopenia in diabetes. Now, how do we screen? Screening protocol for diagnosing diabetic sarcopenia. For screening or diagnosis of diabetic sarcopenia, we use three assessments. First is the assessment of muscle strength, second is the assessment of muscle mass, and the third is assessment of body composition. For assessment of muscle strength, we use the dynamometry, and the chair stand test. For dynamometry, we use what is called the hand grip dynamometer, or the hand grip strength is easy to use. What is called a jammer or dynamometer, hand grip dynamometer, is a validated tool. It is widely used. It's not very expensive, available in the market. And this can be used to measure the hand grip strength. And this correlates with the strength in the other body compartments too. So a hand grip strength of less than 27 for males and less than 16 for females is supposed to be abnormal. It's easy to document. And then the chair stand test, again, this measures the time that is required to sit and rise from a chair 5 times without using your arms. And if you take more than 15 seconds, it is supposed to be abnormal. So this is for abnormal muscle strength or poor muscle strength. Now for assessment of muscle mass, we use the calf circumference. Measurement of calf circumference and then adjusting it for BMI and age. BMI and age adjusted calf circumference measurement. It's an easy and a good indicator of body mass status and functionality. And finally, for assessment of the body composition, we use several imaging techniques like the ultrasound, CT, MRI, or DEXA. So these are the several imaging tools that we use for assessment of the body composition. For example, DEXA. DEXA can be used to assess the adipose tissue, the bone mineral content, non-bony lean tissue, and by assessing all these things, we calculate what is called the appendicular lean mass index. Appendicular lean mass index is calculated as appendicular lean mass divided by height square. And these are the values that are supposed to be below which it's supposed to have a low muscle mass. However, remember, in cases of sarcopenic obesity, it may overstate the muscle mass. So we might miss the diagnosis in sarcopenic obesity. And again, CT scan can help to quantify the skeletal muscle area at the level of L3 level. And the cross-sectional area can be taken to calculate the skeletal muscle index. This is another index that is calculated by a formula, skeletal cross-sectional area divided by height square. Several indices that is used for imaging techniques to document the body functional status. And MRI is supposed to be the gold standard for determining the body composition. In addition to all these things, it can even detect fat infiltration, muscle edema, fiber infiltration, and fiber contracting function and the elasticity. Ultrasound is inexpensive, portable, easy to use, and that can be used for assessing the skeletal muscle thickness, the cross-sectional area, fascicle length, etc. And this is just an image of MRI image of an young healthy muscle and how it looks in a sarcopenic muscle that occurs with aging. Now there is another severity staging of diabetic sarcopenia. Depending upon the sarcopenia and the patient's involvement, diabetic sarcopenia can be classified into 4 stages. Stage 1, 2A, 2B, and 2C. Stage 1 is simple sarcopenia alone, no diabetic complications. Stage 2A is sarcopenia plus diabetic complications. 2B is sarcopenia plus impaired muscle function. And 2C is both sarcopenia plus both diabetic complications as well as impaired muscle function. And this staging helps us to understand the progression of the course of diabetic complications once a patient develops sarcopenia. And this separate entity called sarcopenic obesity. This is coexistence of sarcopenia with obesity. And the prevalence is very high in the elderly. It's almost 27%. 1 in 4 have sarcopenic obesity. And sarcopenic obesity can produce more negative effects than sarcopenia or obesity alone. And early screening and identification of sarcopenic obesity is important to prevent complications of diabetes, and treatment with appropriate intervention measures like diet, exercise, vitamin D intake, all are vital to reduce the incidence and various adverse outcomes. This is just a pictorial representation of how sarcopenic obesity can be caused by aging, skeletal dysfunction, and the pathophysiological changes in the adipose tissue. Now let us come to the final part of our talk, that is the therapeutics or therapeutic strategies for sarcopenia and diabetes. There are several non-pharmacological treatment modalities. That is the most important, mainly physical exercise. Especially resistance training is more important to prevent or treat sarcopenia than nutritional supplementation. Pharmacological treatment, hormonal replacements like transdermal testosterone gels are available, which help to increase the testosterone availability, thereby increasing the muscle mass. And then selective androgen receptor modulators are available or in the pipeline. Then anti-diabetic drugs we'll see in the next slide. And there are future drugs, the mitochondrial targeted antioxidants, targeting antioxidation specifically in the mitochondrial level. And then myostatin antagonists, like follistatin, they are touted to be used for treatment of sarcopenia. Endothelin 1, they are all future drugs for the treatment of sarcopenia. Now, when treating patient with diabetes with anti-diabetic drugs, remember these things. Sulfonylureas and glinides, they have a potential atrophic effect, and hence they should not be used in patients with diabetic sarcopenia. Metformin has shown positive effects, hence can be used. And glitazones have an increased risk of, though pathophysiologically they can be used, but they have an increased risk of heart failure and fractures which can increase the immobility, so they are not recommended. DPP-4 inhibitors have a neutral effect. GLP-1 receptor agonists and SGLT2 inhibitors, they can be helpful, but they are helpful only in specific cases of sarcopenic obesity. And insulin has shown positive effects on the muscle protein synthesis, anabolic hormones, so can be used safely in patients with sarcopenia. And these are the potential approved therapies in patients with sarcopenic obesity. Caloric restriction to 500 to 1000 kilocalories per day, aiming at a weight loss of about half to 1 kg over a period of 1 to 2 months. And then exercises. Aerobic exercises will help to improve the cardiorespiratory fitness. But resistance exercises are the ones which will improve the muscle strength and mass. And then protein supplementation, which will mitigate the loss of muscle mass and strength. And then calcium, vitamin D supplementations have all been used in treatment of sarcopenic obesity. And finally, to conclude, sarcopenia, diabetic sarcopenia and sarcopenic obesity are all common problems in aged adults, and if not prevented or left untreated, they can contribute to increased morbidity and mortality in patients with diabetes. Several mechanisms play a role in the development of diabetic sarcopenia, including insulin resistance, chronic hyperglycemia, AGE end products accumulation, and subclinical inflammation. And screening protocols include assessment of muscle strength, muscle mass, and body composition using imaging techniques. Sarcopenia may be an intermediate step in the development of frailty in elderly patients with diabetes. Frailty is a very important problem in the elderly, and there is no specific treatment for sarcopenia at present. Nutritional supplementation with proteins, minerals, and vitamin D may help, but only if they are combined with exercises like resistance training. And drug treatment options are limited. And always keep in mind sarcopenia when you choose anti-diabetic drugs for treating elderly patients with diabetes. And finally, the take-home point should be that the key strategy should be to prevent a functional decline rather than attempting to recover lost function in elderly people with diabetes. That should be our motto. Thank you all for your patient listening.
Thank you, sir, for the extensive, excellent talk. So, highlighted the importance of day-to-day. We have been seeing patients with adequate weight, but coming with complaints of tiredness, fatigue, and not able to do the day-to-day activities as previously. So we should keep in mind this sarcopenia as a differential diagnose and evaluate and treat. So nowadays we used to give vitamin D for each and every patient who come with that chronic fatigue syndrome and all. So we also highlighted what is the importance of a resistant training and resistance exercises on top of the vitamin and mineral supplementation for sarcopenia. So thank you. So any experience in improving other than these drugs? What can we advise them?
A routine assessment of this sarcopenia, or looking out or keeping in mind sarcopenia while assessing our patients with diabetes, usually we don't have this as a part of our routine assessment. And this is not found out a recommendation in the international recommendations also as part of annual screening protocols. So if we keep this in mind and then only specifically look for this, at least by doing simple exercises and then keeping it as a part of our assessment protocol at least once in a year, then we'll be able to pick up more cases so that this devastating complication can be prevented in our elderly patients' diabetes, at least in the elderly patients' diabetes. Yes.
So open for questions.
Sir,
Any questions, sir?
No, can we?
Yes.
Thank you all the speakers for the wonderful session. Can I call upon Dr. Harikrishnan, Dr. Sadashiva Rao, and Dr. Dharmarajan sir to please receive the mementos? Can I call upon Dr. Professor A. Sundaram to give a memento to the chairperson?